So thank you very much for joining us. A quick agenda for what we're going to do. I will spend a couple minutes at the beginning just to explain to you what the forum is, what our Queen Elizabeth Scholarship Program is, and then I'll introduce you to each of our 4 presenters, all of whom traveled abroad in the fall and had wonderful experiences, which you'll hear about today. We will then do questions for everyone, so we'll do the question period at the end of all 4 of their presentations. And then once that's finished, I'm going to tell you a little bit about our new Queen Elizabeth Scholarship Program, and then we'll move into the other room and have some refreshments, and you'll have a chance to ask our scholars questions about their experiences further. So come on in, have a seat, and we'll get started. So the McMaster Health Forum is the leading hub for improving health outcomes through collective problem solving. We aim to harness information, convene stakeholders, and prepare action-oriented leaders, and work as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and Canadian universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. Here at the forum, our Queen Elizabeth Scholarship Program is called Strengthening Health Systems. Our scholars will contribute to strengthening health systems and become part of our large and growing network of health systems leaders. We have had 3 cohorts of scholars so far. Here is the list of our first group of scholars who went abroad or visited us primarily in the calendar year of 2016. We saw an influx of applications after that first group, and so here's our second group of cohort, our second cohort, which was in 2017. Our 4 presenters today come from this cohort. And our last cohort in this particular Queen Elizabeth Scholarship Program is cohort number 3. We have a number of incoming scholars who will be visiting us in the summer, and then mainly undergraduates who will be traveling in the summer and or the fall this year to conclude this version of the Queen Elizabeth Scholarship Program here at the McMaster Health Forum. Our next and last presenter is Mobeen. So Mobeen, also an undergraduate in the Bachelor of Health Sciences program specializing in global health. Upon learning that African countries suffer from high rates of preventable blindness that can be traced back to systemic and socioeconomic factors, he wished to explore the link between poverty, development, and healthcare. So he interned at the Cape Health Department in South Africa, where he strove to understand the interplay between researchers, policymakers, and healthcare providers to inform healthcare decisions. So Mobeen, over to you. Okay. So Mobeen.
Thanks for that introduction, James. Really appreciate that. All right, so because I was working with the Cape Town government and it was a relatively confidential project, I can't necessarily share a lot of the information. So in that light, I'd like to discuss more so about my personal experience with the Queen Elizabeth Scholarship, kind of my process towards choosing this project, because it was something that I had to kind of search for on my own and kind of set up the experience. I'll discuss more of that, and I will also get into general details about the project so you guys have an understanding of what exactly I was doing within Cape Town. So let me just describe a little bit about how I'll structure the presentation. First off, I'll describe how I set up the internship with the assistance of James and the forum. Then afterwards, I'll describe a little bit about the background of the project, why was I doing the research that I was doing, and then how that research was helpful. And then finally, I'll summarize with a few lessons, specifically just 2 lessons. So first, let me describe the process. So I wanted to do some research regarding the field of eye care and preventable blindness, and the reason was I was part of the global health specialization, and I learned about the social determinants of health, and I was reading about eyesight, and I was really impacted by the fact that it's a little bit more than just an illness, because with your vision, you're able to read, you're able to educate yourself, you're able to have a job, to take care of your kids, you're able to socialize, and in that way, it has such a big impact on these individuals. And I read a stat somewhere that within Africa, again, I might be making up the number, but 70 to 80% of the blindness, it is preventable, and there's a really, really big shortage of ophthalmologists as well as very simple eye care services that in more developed countries, for example, within Canada, some of these diseases, we're not even aware of them and we don't see the impact that they have. So in that way, I wanted to go into Cape Town and kind of see this social determinants of health approach in practice. And I was also considering being an ophthalmologist. I wanted to, in the future, kind of be engaged in the community, so I thought this would be an interesting way to go about that. Now, with regards to how I set this up, I focused more so on the specific topic. So I searched the whole world for opportunities regarding eye care, and I wanted to align with the QES mandate, which was you have to strengthen the health systems, and it has to be within a Commonwealth country. So there's a whole host of countries you could go to. I personally, because considering the financial impact that it would have, as well as the type of opportunities that would be available, and I ended up choosing Cape Town. So some of the more affordable countries, I guess if you are interested in applying, the ones that I thought were down my alley kind of were South Africa, we have the Caribbean, we have Malaysia. There's a lot of others. Those are just the three that I had considered, and there are many others to look into as well. So once I had emailed around the whole world, I spent maybe a few hundred emails. Took a few months to communicate with various individuals. I got maybe out of those 100, maybe 6 or 7 replies. And it did require Skype meetings and communications with these individuals, see what their project was about and whether it would align with my goals. And based on that, I ended up choosing this specific project. So now, this very, very colorful slide, I'll describe a little bit about the actual research. So with regards to the background of the situation within Cape Town, first let me describe the eye care situation within Africa. So I did mention that 70 to 80% of the preventable blindness, it is possible to treat it with very, very simple things. And the biggest causes of blindness, I know these aren't included here, I've mentioned the 5 bigger ones within Cape Town, but those are infectious diseases and cataracts are particularly a very, very big issue, and refractive error. And the way to cure refractive error is simply by giving kids glasses, kids or adults glasses. And that seems like such a small thing, but if you actually go into the communities, you'll see that many individuals, they don't even get screened for what their vision is or any sort of eye condition that they have. And this sort of screening, it's very, very easy to overlook where within Canada these things they're not as prevalent. Specifically with regards to Cape Town, it was one of the economic hubs of all of Africa, and it is relatively developed. So in that light, they didn't have as many of the burdening health issues with regards to eye care that other parts of the country had. So here specifically, cataracts, diabetic retinopathy, and glaucoma were the bigger issues. So diabetic retinopathy and glaucoma, they are both essentially, they cause irreversible blindness by kind of pitching away at the eyesight. Diabetic retinopathy, it's linked to diabetes. Essentially, it starts killing the blood vessels that supply the retina. With glaucoma, there's high pressure within the eye, and that slowly just wills down the peripheral vision, and eventually it can lead to blindness. So these conditions are very, very chronic. So in that way, you can imagine how it would be really difficult to treat them, and they do impose a big burden on the health system. In terms of where Cape Town stands, or where it stood when I had entered, this is kind of getting into the problem now. So in 2009, they actually had a really, really big deficit with cataracts. So cataracts, essentially when the eye just gets very, very cloudy, and as a result of that, many individuals can't see. And this is a really big issue in all of Africa. So to resolve this, there was a big push, and they created this hospital called a high-volume cataract unit, and they did a bunch of research, invested a lot of money into this hospital, and it was just like essentially a factory for diagnosing and treating cataracts, and that did wonders. The World Health Organization goals for cataracts were nearly met, and that was a really, really big bonus. But that was essentially, it kind of stopped within 2014. I mean, the hospital still continued, but that was the extent of the progress. So now we're in roughly 2017, 2018, and we don't, as a city, we didn't have an understanding of what were the numbers for diabetic retinopathy and glaucoma. How many individuals were we screening for refractive error, for glasses, for contacts? How many individuals with cataracts exist? We had absolutely no idea. We were just going off of roughly estimated numbers from 2009. And this poses a big barrier because if you're not aware of what you're dealing with, you can't really go to the government and ask for funding. You can't describe the importance of the disease, and I guess that's the importance of evidence-based medicine as well as public health planning. You need to measure it and you need to prove it to individuals because they have a very different perspective. They want to, for example, politicians, they want to optimize the decisions that they are making. They have to look back to the constituents who trust them in order to make the best decisions. So it's important to keep that in mind. So the two specific barriers that I addressed through qualitative and quantitative means, first off, the fact that there was very little data on the hospital and clinic service outputs. So essentially, we didn't know how many cataract operations were being done, how many glasses were being outputted across the country. as well from the literature standpoint and from the country standpoint, the burden of disease. So this would be epidemiological research that would be published in mainstream research journals across the world, specific to the South African databases as well. And the second point is more qualitative. There was no real collective understanding of what the priorities amongst the service providers, so individuals like ophthalmologists, opticians, optometrists, as well as just nurses that were doing a lot of the screening, what their perspectives were, what they thought priorities would be, and this was there's a really big deficit in this. So one point to highlight this is the fact that the last eye care report, it was actually written in 2008, and since then, which is roughly 10 years ago, nothing else had been released. But if you look at, for example, within Canada, every 4 to 5 years, there's a new mental health strategy. There's a new strategy regarding updates of what the burdens of disease are, as well as what the next plans would be. So this was really, really lacking. And just hit this home one point further, there was no eye care committee. So next I'll talk a little bit about how I address this really, really messy situation. Well, not me alone, but in conjunction with a lot of individuals. So let me describe a bit about the mandate as well as my workplace. In terms of the mandate, it seems like I'll be flowing into this anyways, but I was essentially working on the eye care strategy, and I would identify implementations to barriers, as well as what the next steps would be. So I was working at a Victoria hospital, which is a small hospital. I think it was one of the 8 or 10 within Cape Town that had eye care services. I was working with Dr. Melvin Wootley. He was the CEO. Unfortunately, I wasn't part of a team. That made the situation a little bit more messy because I was kind of just put out there. I had to work alongside the Western Cape government, and this was an individual, it says green building, it really wasn't green, but these individuals, or public health officials, some of them were statisticians. I didn't know, I pretty much knew nothing, and I didn't have any teammates. So I spent a lot of time Googling, and I spent a lot of time creating a research question, so in that way, my project was a little bit different. And this is pretty much where I was located. In terms of what my days would look like, they had a special office in the nursing department where I had a desk, and that's where I was able to work, and I could use the hospital phone in order to contact the other hospitals and clinics that I would be visiting. So it's a little bit unconventional. It's not really associated with a university per se, but I did have a bunch of contacts with universities across Cape Town. So that's a bit about what I was doing. So let me describe how exactly I went about doing this. So first off, with regards to quantitative information, the idea was to understand the output that the hospitals were putting out, as well as what the needs of the individuals were. And when we could compare this, we could see what the gaps were and where future steps could be. So there's 2 ways of doing this. The first would be regarding the output of the specific institutions. So the way that we ended up doing this was in consultation with the CEO. Because I'm sure there are many, many different ways of doing this, but my CEO, because we were in a really resource-limited setting, he suggested I pretty much just go to the hospitals, ask them for their raw data, which was stored in really, really different ways specific to the exact hospitals, and then just do a bunch of number crunching, put them together in the end, and present them to a committee at the end. So in terms of the research process, it's nothing fancy, but this was what he had suggested, and that's mainly because I was working on the project alone, and it was really, really severely limited in terms of the budget. So in light of that, I suggested that maybe we should try to find something more holistic, also compare the research information that was available out there already. So at the end of the day, what we ended up doing was I went to various hospitals across the city. So this included the pediatric hospitals, the more tertiary, really, really specialized hospitals, as well as clinics. And because there's many, many clinics, I think there was like 40 or 50, I ended up, for the sake of time and efficiency, we resorted to the provincial database, which is called Clinicom. That had many, many challenges of its own, particularly because unlike Canada, there weren't many electronic medical records of the patients, and a lot of files that were actually done on paper. And as you would imagine, because this information is often on paper and on electronics, there was a bit of a gap. So the information was definitely lacking in that regard. Now, the second part was regarding the epidemiology. I know I was tasked to do essentially a literature search on the diseases I mentioned earlier. So cataract, diabetic retinopathy, where kind of is the situation since the last 10 years. It might be a little bit surprising, but since 2009, there was no new research published. And I searched for a long time. I tried to update specific search strategy I had. I was like pulling my hair. I was like, well, what am I going to show? I was so embarrassed. So then I contacted my CEO. I was like, I tried my best search strategies. I searched all the South African databases. What do I do? And he said, if this deficit that does exist and you tried your absolute best, then the process of trying to find out new information, it does show a gap in the research and it does show something to work towards. So I think reaching out to my CEO was very, very helpful in that way. So that's the quantitative side specifically. With regards to the qualitative information, as I mentioned earlier, I was going through hospitals across the city as well as various clinics. So what I ended up doing was conducting interviews, and the point of these interviews was to understand what were some positives and negatives of how the system currently works within these individuals' clinics, understand their perspective, as well as see where they think the field of eye care would or should be headed in a few years, as well as some barriers they might have. So again, because I was doing this on my own, I kind of came up with a rough outline. I told my CEO, listen, I'm thinking of asking these few questions. Do you have any sort of feedback? And based on that, this was how I went about the interview process as well. So these 2 pages, I'll be discussing the quantitative and quantitative findings. So it is a little bit to digest, and because some of the information is confidential, I'll just try to summarize what I got out of it as well as just a general summary. So I've included the 3 main pathologies. We have cataracts, spectacles. My CEO, he always called them spectacles, so I thought maybe that was a lingo, but that just means glasses or refers to refractive error if any of you were confused. And then diabetic retinopathy / glaucoma, because the glaucoma data was absolutely terrible. I couldn't even look into that. And even diabetic retinopathy, if you look at the statistical burden of disease, which was extracted from epidemiological research, it says 6 to 10,000. That's a very, very huge range. And as you can see, the estimate that it would impose in terms of the burden of people that can't afford it, that's also a huge range. And if you look at the red on the furthest right, it says needs more information. So in light of that, there's not much to say there, but it just shows that there is a really, really big need to do research regarding the epidemiology as well as the outputs that our hospitals are putting out. So with regards to cataracts, I mentioned earlier the Cape Town government was doing a good job of meeting the needs. It was actually very close to the WHO goals. So in terms of that, there's not much progress that could be done. And this can be seen in, if you look at the columns of GAP 2016, essentially how I got to that number is I took the burden of disease and multiplied it by the population that was uninsured, and that kind of gives us how many individuals we need to be caring for, and then from that I would subtract the services that are being given out, and then if you subtract the two, you get the individuals who are uninsured and they aren't being cared for currently. So next we'll talk a bit about the spectacles or the glasses, and this was a little bit of a tricky issue because it wasn't necessarily under it wasn't run by a specific body. They actually had hired a private company, and they noticed that the company actually wasn't doing a good job of reporting how many individuals they had screened, as well as the glasses and contacts they had given out. So in terms of that, I had to pretty much just play with the numbers because they only submitted the data for half the year out of their 2-year term. I asked supervisor, if you pay these guys, shouldn't you kind of know what's going on? But it was really shocking, actually. And he said, all right, actually these guys, we canceled their contract as a result of that. And I think it's just the reality, the fact that even at such a high level, sometimes these private organizations, they may not perform to a standard. And it just highlights why it's so important to have the evaluation and monitoring process, as well as measures in place to ensure that organizations are doing their fair share to meet the needs of the population. And then from that row, I guess the big takeaway is, I put question marks here actually in terms of the estimate and the gap, is because these contractors, they didn't give information for a year and a half, I couldn't tell if we had addressed a need. I could just say that the gap had increased because the population of the Cape Town city, it went up by 300,000. And I just multiplied that by a rough statistical burden of disease, again, which was a little bit outdated. And it just shows that, we definitely need to address this area again. And the kind of implementation concern that I had put was to address whether this public-private partnership is effective. Why are other parts of the country not doing the same thing? And, I said maybe you should look into the evaluation and monitoring and perhaps enforcing stricter rules for data monitoring amongst these organizations. And again, just for diabetic retinopathy, Summarized in 3 words, requires further research, and this is both at the hospital level, but also at the level of the epidemiological research. So these are 3 main takeaways that I had taken from roughly 8 to 10 interviews with different individuals. There are a lot of different bullet points, so I'll just summarize them by category. So the first point is regarding the inefficient use of specialized clinicians. So out of all the hospitals I visited, there were some that were very, very tertiary. They were dealing with very specialized patients. So these patients, they couldn't just be seen by any doctor. They couldn't be seen by a nurse or even like an optometrist. They had to be seen by an ophthalmologist who had special equipment and special training to deal with their conditions. But unfortunately, and to my shock, many of these ophthalmological consultants, they were actually seeing a lot of simpler cases that other individuals could see. And as you can imagine, that costs the system a lot of money because they've invested so much money into their training as a result of the skills that they have as well, these ophthalmologists. They also do charge a lot. And on top of that, there's really, really long wait times for individuals that have specialized cases. And this essentially results in a really, really big clogging of the system. And, when I went to talk to this one hospital director, he was so concerned. He said, it's really simple. All you have to do is divert individuals from these tertiary hospitals, and that solves everything because then we can see specialized cases. So I'll talk a little bit more about this later on, but just shows how every individual, based on the work that they do, the education that they have, the perspective they have, their solution to the situation will be very, very different. So next, my favorite is diabetic retinopathy and glaucoma once more. Both these chronic conditions, because of the fact that they are chronic, it's been really difficult to measure the burden of disease that they have as well as the services that we are currently outputting. And I'll describe one specific anecdote. So when I went to this major hospital, it's called Houtier Hospital, one of the biggest hospitals in Cape Town. They weren't actually jotting down the number of diabetic retinopathy or glaucoma patients within the electronic medical records, but at the same time, they were being jotted down when they were being billed. And I was very shocked. So that means that the clinicians or the individuals working there, they're putting in effort to jot down these individuals in terms of the payment, but when it comes to research purposes or just monitoring of the patient, it wasn't there. And I was very shocked by that, but it does show that there definitely needs to be an area of focus. Within a hospital, you should try to monitor the needs of your patients as well as the different types of patients. And when we talked to these doctors, the supervisor, he took me to different rooms and we talked to 2 or 3 different practicing doctors there, and they said, oh yeah, 75% of the patients, they are diabetic retinopathy or glaucoma patients. And this is anecdotal, but if we were to look for the data, we couldn't prove that whatsoever, and we can't just go empty-handed to the government or other stakeholders and say, listen, these doctors, they say it is so it must be. Again, it just highlights the importance of having measures to monitor and store all of this data. So next, again, this goes to data again, but this is specifically regarding clinic level information management. So the administration staff, so when you go into an appointment, you see the individual, they write down when your appointment is, the reason for the visit, as well as just managing the flow of the specific clinic is very micro level, but even this deficit, it was really, really easy to see this. So these admin, they were so overworked and they were also understaffed, and that's understandable because there was a shortage of finances. But at the same time, because they were working so quickly, I felt like they did make more mistakes. Oftentimes there were errors in referrals. And as a result of this, I actually noticed within the facilities, there was difficulty sharing information. So, for example, if an individual comes into the hospital for a trauma eye condition, for example, they'll be seen by the eye ward. But at the same time, if you kind of wanted to pull up information regarding this patient for perhaps, I don't know, maybe if they had a bone injury or something, this information wouldn't be in the same place, and the other parts of the hospital, they wouldn't know this patient came in for an eye operation, for example. And that was very shocking, but again, it does show that there was a limitation of resources, and just because we have these tools here, we do seem to underappreciate them a little bit. And that's just one major point that came across all hospitals. So, overall, although these qualitative findings, they do seem very, very simple or obvious, I did actually notice them in play when I went to all these clinics, and all of the individuals I talked to, the clinicians, they were very concerned. These were big issues for them, but it's not easy to solve. Just first of all, there's the money aspect, but also the fact that it's difficult to implement change even if you have data. So I guess it highlights again what Tamina said, implementation is a really, really big part of the process. So these are my two lessons, but I'll start off with number one. This was the biggest takeaway I had, and it was regarding interprofessional collaboration. So we have a very wonderful picture. I'm practicing my photography here. It was a meeting at 7 a.m. with, I think, really, really big stakeholders. It was like various ophthalmologists, heads of ophthalmology across the country. I was scared. I was very scared. So I came in an hour early. I came in saying, I understood the feel of the room. I practiced my presentation. And the reason being is it's one of my first lessons, the fact that background research and preparatory work is so important, and that's also part of the learning process, right? So any question I had, I would jot down potential resources. I would go out and research. I would read a lot of papers. And if those research papers couldn't answer the question, then after I had that base, I would reach out to my supervisor and other individuals if needed. This was a really lengthy process because I didn't even know where I was in the country, where the hospitals were, what the names were, and there was like oftentimes an assumption that you should know these basic things, and very rightfully so. You are going into a different country, and you should have some sort of expertise, even if you don't have the background education necessary. And this was really important because when I went into specific meetings, I could kind of stay toe-to-toe or at least follow to some extent what these clinicians were saying, and they moved very, very fast. So it was important to be able to do this. So the next point is understanding the research question, as well as knowing what information to zone in on, what type of questions to ask. And the reason why I'm highlighting this is because I was working with many, many different stakeholders, and they all have their own perspectives. So first off, for example, when I went to the individual who ran the hospital, he said, okay, we need to divert these lower level cases to, we need to decant them. Other people can see them. We don't want to clog the specialized physicians. I was like, well, that seems very simple. Then when I went to a clinician, he talked about having continuity of care, having an appropriate referral process, understanding where the patients come from, etc. And then other individuals, for example, when I went to a data scientist, he said, yeah, no, we need more organized data, and that would solve the problem. So in that way, when I kept going to different individuals, I was wondering, where is this project headed? What am I doing? Why are they giving such varied information? So I stepped back a little bit. I had a meeting with my CEO, and then we kind of discussed where the project should be headed as well. We zoned in on the research question. And at the end of the day, he said, hey, listen, it's up to you kind of where you want to take it. This is where like your creative license does come into play with regards to the research process. And I found that quite valuable. And I will remember that going into the future. Finally, importance of thinking on your feet. The reason why I studied this is because I have one specific example I'd like to highlight. So I went into a pediatric hospital. I was giving I had obviously done my preparation work. I knew what kind of questions to ask. I was giving my little spiel, my background information. And then the ophthalmologist, she had done ophthalmology for 15 years, so she obviously knew what she was saying. She was very snappy. She interrupted me midway. She's like, all right, but like, how is this useful? Like, what am I going to get out of this? And I was like, okay, let me think about that for a second. I was really put on the spot there because it was like relatively informal and she kind of like got right to it where I was used to talking in a very professional light kind of, I thought it was relatively clear. But in this way, she did challenge my opinions a lot too. And I was wondering, I'm not the researcher, I'm interning here, I'm trying to learn the process, please go easy. Like, these are just thoughts in my head. Obviously, like, I maintained professional conduct and I tried to speak the best way possible and use my background information. But it is important to be able to think on your feet and just highlights the work that you put in, the value that it does have, and the fact that you represent your country as well as I was going on behalf of the forum, so I didn't want to disappoint James as well as the forum, right? So in that way, it's important to think on your feet, not just for QES, but any other project as well. So next, because I went to South Africa, there was just a lot of cultural, religious, and social richness. It's a very, very general term. The reason I said this is because I'd like my experience to be relatable to you individuals. So first off, I'll talk a bit about the religious side. So within Cape Town, there was a very, very big population of Muslims. And as someone that was from Pakistan, I left the country when I was roughly 2 or 3 years old. So I would say I didn't have the strongest cultural or religious childhood. But I was really lucky that at this age, I was able to take some time off. I had 3 months to reflect on my goals, my values, my worldview. And it was really easy when you're outside of the school or academic setting or when you're able to dissociate work from school. And in that way, Cape Town had 108 mosques or something like that. There was a mosque within every few kilometers. So even within the club district or entertainment district, somewhere you wouldn't expect to find a mosque. I was walking down that place just because it's good to, see the city. There was a mosque right in the middle of that. So I was like, wow, that's cool. So I actually got to go to a few different mosques. And that was very, very culturally rich for me. Well, I personally thought I would go see lions, go see all these sites. This was one of the most valuable things for me specifically, and because I became so captivated by this, I never actually ended up going to a safari, which is fine. I told myself there's other opportunities. And I personally don't regret it whatsoever because it was really valuable for me. I spent my time reading up on Islamic texts and just the general community as well. Next, I'd like to talk a bit more about the culture. So I was actually on my way to find a specific place of residence for 3 months. I ran into a taxi driver. I said, do you know anywhere I could live? Any good recommendations? He recommended a Muslim community, and from there I was very, very fortunate to be living with individuals who were actually from Malaysia originally, and they had immigrated to Cape Town, I think roughly 80 or 70 years ago, so they're essentially Cape Townians, and they were very, very welcoming and very respectful because they were also Muslim. I was really able to understand their point of view, and oftentimes we had dinner together. They took me to a bunch of their family events. Nothing that will happen in any of all of your trips, for example, if you were to go. But because I had this opportunity, I was able to live like a local, understand a bit about the food, the type of education, type of issues prevalent in society, and that was very valuable. And finally, the last point regarding the social richness, I'll talk specifically about poverty and apartheid. So with regards to apartheid, I'm sure many people here would know a lot more than I would, but I was just firsthand able to notice the segregation and the effects that it has on society. So for example, there was this one place called Constantia, and just by the name of it, it does sound very fancy, and it was. All the houses there, they essentially look like palaces, and the backyards were humongous, and the cars were very, very fancy. It felt like I was in Europe. It was very beautiful, but at the same time, I was very shocked because I thought, I thought the country wasn't doing so well. And it's as a result of it's not as a result of And, Cape Town does have one of the highest Gini indexes, which I believe represents disparity in income. And this was shown very, very strongly. And if I went maybe 4 kilometers and I went to the left of one bridge, you can see a difference in the houses. And that's where individuals, they lived in the slums, for example, or they barely had electricity and the running water wasn't as clean, for example. And that was just very, very prevalent. And often these individuals living in those slums, they used to live in Constantia, or they used to live in that area that was very wealthy. So they were the owners of that land. And the government at the time, they had literally plucked away their land and their what they owned and moved them to these poor areas. And that was very, very shocking and eye-opening. And with regards to the poverty, there was one specific city that really it did shake me to the core, and I became a little bit upset. It was a place called Khayelitsha, and it's essentially, if you can imagine a shack with five metal sheets, roughly the size of maybe a washroom. That would be the house for individuals with family size maybe 10 to 15. So pretty much they would have to lay on the floor like hot dogs, for example, something like that. It was really, really shocking. And this city, Khayelitsha itself, there were millions of these shacks. So these shacks, these comprised the city, and the roads were just dirt in between the shacks. And that was very, very eye-opening, and it was humbling, and I was really grateful for this opportunity, as well as the things that I do have within Canada, the learning opportunities that I've had. And in general, I would say the fact that I went to Africa, it was a little bit of a risk, and I'm grateful to the QES team for the funding and support throughout the journey, and I did find this process very valuable. Thank you for your time.
And we'll open it up now to the room for anybody who has a question.
So this is a suggestion from my father. He said because I didn't really understand the country as well, he said, okay, so book a place for like a week or 2 weeks because then you have some place to stay. And then before you make the 3-month commitment, for example, go ask around, learn about the areas, and then based on that, you should make your commitment. And I think that was a good idea because I actually changed houses 3 times within the first week. And I'm really glad I did that because the third house I found, I stayed for 2.5 months, and it was probably the best choice. So I would also recommend that too. Very good question, Puru. So in terms of just adjusting to that, I think first off, I'd like to highlight that everyone is very, very friendly, and they do have a really human side of them. So it was really easy to connect when they were cracking jokes about having cookies or just eating a lot, etc. Like it was a very common joke because in Cape Town they eat a lot. So first, just recognizing that you're a student and the fact that they also recognize that you don't know everything. Aside from that, because there's so many interprofessional meetings, people had different background knowledge, so as a result of that, they did treat me as someone who had a specific objective, so they knew that I was here to discuss my research process, discuss the obstacles I face as well as my point of view, and work alongside them. So viewing myself as a team member, someone with different skills was one way to accommodate, and also just knowing that because, as others have mentioned, we are there to learn as well, but also contribute, asking a lot of questions, and sharing that we're really engaged in the process, as well, the fact that I did all the time to do my research just shows that I was involved, and it helped me become more comfortable. So it was just it's something that you will only know once you actually dive in, for example, yeah.
Yeah, for sure. I think the one that comes to mind immediately was in Broken Hill. So I guess one of the reasons actually that Broken Hill was chosen as a community was that it does have one of the highest Aboriginal Australian populations there. And so it was definitely, I was able to see this disparity between the types of services or even the way in which the town looked compared it to perhaps Albany, which was a coastal town. They had a history of whaling, things like that, so they had a little bit, I guess the financial situation was a little bit different as well. And so I could definitely see that contrast. And then even in my own personal travels, obviously up to Sydney and the Gold Coast as well, which is another community that we were working with. I could see the ways in which being more rural or more remote, kind of like in Canada as well, it can lead to certain inequities in terms of the resources or funding that you can access. And I was especially interested, I guess, in looking into that difference between the Aboriginal Australian population and the larger Australian population. And so that was kind of prevalent, especially when I went into the more rural or remote communities. So,
I think for me, my biggest asset was kind of actually my ignorance, because I didn't come in with any preconceived notions about what things should look like or how things should be. So much of my work before kind of making recommendations, which is part of the work that I did, but so much of it was just characterizing the landscape, and I did that with a fresh set of eyes. And I think that a lot of people who were kind of looking at my work were noticing that I was picking up on things that they had always glossed over because they were just so familiar with it. I was able to look at it in a more critical lens, and I think that was valuable because of the work that I was doing specifically.
Yeah, I would say for me, literally my time, I guess, my effort, because the way this project was so fast-paced. When I went there, I was thrown into the middle of this data collection meeting, and I was so lost, and we were moving so fast through all the different communities, and this was a component of work, this literature review that they needed to have done, but there wasn't really anyone to do it. So I think that was an asset I brought, is that, I guess, that ability to contribute to the team and do something meaningful, as you were saying. This is a piece of work that they needed and they wanted, they just didn't have the time to do it. So I guess that would be something that I brought.
Yeah, similar to Tamina, I would say just this ability to ask questions, coming in from, again, a fresh pair of eyes. And for me, what they found really interesting was that they had no idea that I worked on a health tech startup, and I'd sort of brought in my understanding of software, and I was like, hey, what you're studying is actually a lot like this thing in business. And they were like, we did not know that. So it was just this idea that you're coming in with your own unique background, and you can point things out and ask questions that they wouldn't necessarily have thought of otherwise. So it's just another diverse person to the mix. When I describe, I've tried to describe what I brought in from other things, and I think it's really not about necessarily content knowledge, but about really just this ability that you come in with to be able to find that information. So the skills you've built up over the last couple of years of undergrad in finding information and taking initiative and sort of confronting those challenges and asking for help are probably going to take you much further than a particular course in the program will.
Yeah, I just want to really kind of reiterate and reinforce that the inquiry process and learning how to ask questions, that shouldn't be understated. You would be surprised at how many people don't know how to ask good questions and don't know how to find answers to them. And it's not about knowing things, but about being able to get to answers, and having kind of that those strong research skills. And I don't mean like wet lab research or anything like that, but I mean kind of critical thinking, critical analysis, being able to analyze a piece of, literature and understand what it's really saying versus what it thinks it's saying and that kind of stuff. And all of that, I mean, critical crap, for instance, health pol, all of those courses kind of teach us those things. So I think, was it Jessica actually was it you? Sims, actually, this idea of co-design. So I think in the work that I'm doing, kind of like in health of innovation, both in Toronto and then that I kind of did in Leeds as well, co-design is this idea that the people that are going to build the solutions and the people that are actually going to use them and be the people who are kind of maybe part of the problem, not like the problem, that is, and maybe they have that health issue or whatever, they're all together in kind of the ideation phases to talk to each other, to communicate, to understand, like, what do we want this to look like realistically when they're left out of that decision-making kind of process in the early stages. That's where some of the implementation issues come in, because when it comes time to implement this, because the clinicians were not there and it was just maybe a bunch of researchers and some engineers, they can't foresee certain things, right? And having those perspectives are really important in being able to catch them early on, implement them into the design of whatever it is you're working on, whether it's a policy or a piece of technology, and then that addresses kind of some of the issues that come later down the road.
I guess having a policy window or political and social environment that is conducive to results, it really helps push the process forward. And just to re-highlight, engaging multiple perspectives, having certain deadlines, and something to really push forward the implementation, I think really helps. So for in my case, we were so limited on funding and because there's no specific committee, it was really hard to implement and push things forward. I think that's where like the policy window or having some sort of impetus would be really useful as well.
I mean, I think with me, so like in terms of scale, like we don't have like a Canadian health system, right? We have the Ontario health system, and the Ontario health system is so much smaller than the NHS. It's just in terms of the number of people working in it, but also the resources and funding available. But I think coming back from the NHS and seeing how, I mean, there's always this joke that the NHS is behind because they're just kind of like this big lumbering organization and they think they're not innovative. I thought they were actually really innovative, and I came back and I kind of took that back to my team in Toronto, and I was like, oh, they're implementing like these types of programs. They have this kind of government support that just doesn't exist here, and everyone was a little shocked. Like they didn't realize that that was the case, and I think that we do have a lot to learn from them in terms of the way that they go about funding and supporting health innovators, which I know is like a very specific thing that not everyone's interested in, but that was something that I took away, realizing that they were a lot further ahead than we were, but just because we're kind of newer and shinier, people think that's not the case.
So I'm cognizant of the time, so I'm going to draw to a close, and I want to thank all of our scholars again for their presentation. So give them your appreciation. To today's session. That first link that's on the screen right now is the link to our scholarship page. So when we do update it and we announce the application window, that's where you can find it. We will continue to have webinars. So we are at the end of the webinars for the second cohort, but of course our third cohort, all of those students will be conducting webinars in the future when they come back. So look for a series of webinars in the fall, and they also all write blog posts. So all of them write a blog that is posted on that third link, the MacHealthForumScholars.com website has blogs from all of our scholars back to the first cohort. Gives you an idea of the more personal side of things. And all of the scholars that you saw today will have a blog post there as we go along. So thank you for coming.